Immunotherapy 2016, ASCO, here it is. You can't get away from it. Every room has it. You walk into it. It's definitely a dominant theme. It's changing oncology. I've been involved in immunotherapy for over the last 10 years when I actually was head of the melanoma program at Memorial Sloan Kettering before coming to Columbia. So I've seen the evolution of the field. Sarcoma is a complex cancer. It really represents 60 different cancers, and that makes, when you're a sarcoma doctor, you're not just a doctor for one cancer, you're a doctor for 60 cancers. So that's a challenge when you're trying to develop new therapies against 60 different subtypes of tumor. And as a field, sarcoma is considered an orphan disease. We don't get the attention of lung cancer or of colon cancer. So how do you get big pharma interested in sarcoma trials? Well, they do test it, but the studies are quite small, in part because the commitment isn't as high as it would be, say, for lung or colon cancer. So we saw several studies presented today looking at the effects of immunotherapy in sarcoma. The first was a study presented by Dr. Taubey from MD Anderson, looking at the effects of a PD-1 inhibitor. PD-1 is an immune checkpoint that's involved in regulation of T cells. There are several drugs now that block that checkpoint. By inhibiting it, you turn on the T cell and, in theory, activate immunity against cancer. So this is the first study today presented, actually ever, looking at the effects of a drug called Nivolumab, Pembrolizumab, there are several of these, so Pembrolizumab as a drug that blocks the PD-1 pathway. Overall, looking at the data, it was a bit disappointing. The response rates were probably no more than 15% overall in about 85 or 90 patients. The complexity then again in sarcoma is, what about the sarcoma subtypes? Were there signals of hope in certain subtypes apart from the whole? And in fact, there were. In a tumor type called undifferentiated pleomorphic sarcoma, complicated name, also used to be called malignant fibrocystiocytoma, it makes it even more complicated. But in that sarcoma subtype, there are about 6 patients treated with pembrolizumab, and actually 4 of the patients responded, which was quite unusual and unexpected. Also in a subtype called liposarcoma, again, a rare tumor in the United States, about 3,000 cases total, but actually a common sarcoma relative to others. There were about 4 patients with this sarcoma subtype treated, and there was 1 responder. And that's the problem about this study, that when you do a study of 85, 90 patients and 60 different subtypes, how do you include all the subtypes in a small study? It's impossible. That's the answer, right? So how do you do that? And that's one of the difficulties we face in sarcoma field. How do you make sure that all the patients and all the subtypes are adequately treated to answer a question of activity in all the different types of cancers we see within sarcoma? So if you look at the whole, yes, it would be considered disappointing. The overall response rate is in fact quite low. But if you look at the sarcoma subtypes, there was a signal of hope that there may be some ways to build on that and expand those subtypes in future clinical trials. There's also a responder in one bone tumor called chondrosarcoma, though the overall responses in bone tumors such as osteosarcoma and Ewing sarcoma was quite low. So we have to look at the positives, not the negatives, and despite a negative trial, I still see some positivities in it. Now, what was really negative, interestingly enough, was the study presented by Dr. Suzanne George from Dana-Farber, and she looked at the effects of a PD-1 blockade, in this case with Nivolumab, another PD-1 inhibitor, in uterine leiomyosarcoma. And in this study, there was really no activity, almost no, one responder. And the question is why? So in fact, they're looking at that quite closely. There's a study I'm undergoing looking at the DNA in that patient, trying to understand why that responder was so high. And that speaks to the next step in sarcoma. How do we understand who responds, who doesn't respond? You know, a 1 response out of 20, 25 patients. Well, what's special about that? What's special about this undifferentiated pleomorphic sarcoma? What about that 1 patient with liposarcoma? Can we take that tissue? Can we analyze it? Can we look at PD-L1 expression? Can we look at immune infiltrations? Can we look at other potential biomarkers? In fact, that was a third presentation today at ASCO, looking at other biomarkers that may help predict responders versus non-responders. Now, this is all very theoretical. They mentioned a target called IDO, which seems to be highly expressed in many of the sarcomas that we treat, and in fact, there are IDO inhibitors in clinical trials. So the question that comes up, well, should an IDO inhibitor combine with the PD-1 inhibitor? And that's where we're going forward. In fact, not just for sarcoma, but for all of immuno-oncology. How do we combine these drugs? What are the best combinations? What are the signals, the proteins, the immune infiltrates that are going to divide the next step in this therapy? So sarcoma is at its infancy. It's just really starting. We have some overall studies that you could say were negative, but I say there's still hope. That in those studies there are pearls to take lessons from. We're going to build on that. We're going to take that forward. We're going to understand those sarcoma subtypes. So in ASCO 2017, we're going to come back and say, we built upon what we learned in ASCO 2016, and now we're really trying to find ways to cure sarcoma with immunotherapy.